So upon the range of motion screen, the patient may feel pain with range of motion, and also during the transabdominis and the multifidus assessment, the muscle recruitment would be variable and harder to recruit the muscle.
Okay, so for palpating the sacral base and the PSIS, I should expect to see the PSIS is more prominent. So just palpating here, I see that the PSIS should be posteriorly rotated. There should be no tender to palpation at the long dorsal ligament, but I can tell that the glutes and the hamstrings are hypertonic upon palpation.
Okay, so for a patient with an IS dysfunction, you will often see that their SI joint and buttocks have pain upon palpating. There's also pain with increased weight when the pelvis has to move while walking, and there's pain in end range flexion and extension. Additionally, you'll feel a hypertonic buttocks and hamstring muscles.
Okay, so what I'll do now is BMC for the IS. So I'll palpate at the PSIS that I think is posteriorly rotated right here. I'm gonna have my other hand around the opposite ASIS for counterforce. So I'll do superior force right here, and I'll ask the patient to flex down. Okay, come back. And I'll ask if that changed any of the pain or range of motion, and I'll assess if he had less difficulty flexing. Okay. So what I'm going to be doing now are the breakouts for determining the IS dysfunction to determine if the patient is anteriorly rotated, posteriorly rotated, or if they have an upslip present. So I'll palpate right at the PSIS and the sacral base of interest. So what I'll do first, I'm going to have you flex your right hip up, and that's determining if they have anteriorly rotated ilium, so it's unable to posteriorly rotate. I'm going to palpate, I'm going to keep here, and I'll have you take a step forward with your left leg. And what I'm checking here, you can come back, what I'm checking here is if the patient has excessive posterior rotation, so they're unable to anteriorly rotate. So now checking for an upslip, I'll determine that the PSIS and the ASIS are both translated superiorly, which can be due to a hypertonic QL or trauma. And I can do that with both the anterior rotation and posterior rotation tests. Okay, the second breakout I'll be doing is the leg length discrepancy breakout. What I'll do is I'll check if there's one leg that's longer than the other. And what I'll have you do first is, can you bend your knees, both knees for me, and go into a bridge? Okay, come down. And then I'll have you relax your legs. So what I want to notice is if one leg is longer than the other, and it looks like I'm palpating by the medial malleolus, just inferior of that. Looks like the left leg looks a little bit longer, so what I'll have you do now is sit up and see if that changes, corrects the length of it, and it looks like it did, so I would classify that as a functional leg length discrepancy. All right, now I'll be moving into the treatment phase of the examination. The treatments are going to be based on my findings from column 3. So what I'll do for my first treatment is do an IPT correction, where I'll induce a posterior rotation of the pelvis that's stuck in anterior rotation. So I'll come behind here, palpate at the PSIS and ASIS, make sure that I have the right landmarks. So I'm just going to induce posterior rotation at the right side and an anterior rotation on the left side, and have the patient go into flexion. All right, and I'll know that worked if it fixed any of the comparable signs, mainly the range of motion and the pain.
All right, so I'm gonna perform the Dong-Tini technique next. That's gonna help for SI distraction. So what I'll do, have the patient's knees bent. I'm gonna feed my left arm through the right leg and bring it up like this. So I'm gonna distract anteriorly fixated ilium. So what I'll do is just bring the hip out and then sort of crank on the knee flexion. Hold it there for the patient to feel a distraction, and then relax. And hold it there and relax. And I'll just do that a few times. Okay, so now I'll be doing the MET to fix a right anteriorly fixated ilium. So I'll have the patient on their side facing me. Can you come a little bit closer to me? And can you straighten out your bottom leg and lock it out? Okay. And now I'm gonna induce hip flexion of the right ilium to get a posterior rotation. So now I'm just gonna bring you to further flexion. Can you straighten the leg against me? And I'm gonna hold it for about 5 seconds and then relax. So what I'm essentially doing is giving an isometric contraction, and that's going to allow for further hip flexion. And then once I do this a few times, I'm gonna have the patient relax and assess if that worked and gave the patient further neutralized rotation of the ilium.